Good afternoon, everyone. So you're very welcome to today's webinar. My name is Michelle Leach and I'm Professor in Radiation Therapy here at Trinity College Dublin in Ireland. So you're very welcome. This is the 6th of our CPD webinars this year. And the reason why we have these webinars, of course, is for continuous professional development education for radiation oncology professionals. So if you have missed any of our previous webinars, you can catch up with them on our website, tcd.ie/radiation therapy. And of course, today's webinar will also be recorded. So that's enough from me. I'm now going to hand over to the chair of today's session, who is my colleague, Assistant Professor Sarah Barrett. Thanks, Sarah.
Hi, Michelle. Thank you. Yeah, so my name is Sarah Barrett. I'm Assistant Professor, as Michelle said, here in the discipline of radiation therapy. So today I'm delighted to moderate this webinar, which, as Michelle said, is part of our series organised by our discipline. And we're very lucky to have Professor Gerry Hanna delivering today's topic. So I think he's probably a man that needs no introduction, but I will mention he is a clinical oncologist with extensive experience in lung cancer. He's a former director of radiation oncology at Peter Mac in Melbourne. He's the former chair of a division of Northern Ireland Cancer Centre in his home turf of Belfast. And we're really happy to say he was recently appointed as the Marie Curie Chair of Clinical Oncology here in our discipline in TCD, and has a clinical role, a consultant in radiation oncology with St. Luke's Radiation Oncology Network in Dublin. So Professor Hanna is going to speak on a very topical issue today, which is radiation therapy and the management of stage 3 non-small cell lung cancer. There'll be lots of time for questions at the end. Just to note that the chat function doesn't work in the webinar setup, so please type questions into the Q&A box. We'll be monitoring them and put all those questions over to Prof Hanna at the end, so there'll be time at the end, or feel free to do it as we go through the session, and we'll be keeping an eye on those. So with that, I'll hand over to yourself, Gerry, and thank you very much for giving us, I suppose, an overview and sharing some of your insight on this topic today.
Sarah and Michelle, thank you very much for the lovely introduction. And just to say, it's lovely to be in Trinity and lovely to be part of the team down in Trinity College Dublin. So we're going to take you through today radiation therapy, the management of stage 3 non-small cell lung cancer. And this is now a vast area that is, ever changing and changing every year in a way that it's never done before. So that rate of change has certainly become exponential, so to speak. That's just my email address and Twitter handle for folks who want to contact me after the session today. But hopefully you can see those slides well. These are just my disclosure statements. And now today, what we want to go over today is basically defining what is stage 3 non-small cell lung cancer and how we might assess patients for treatment. Think about the indications for radiotherapy in stage 3. Think also about the optimal radiotherapy delivery techniques that we might use in non-small cell lung cancer. We'll talk about altered fractionation and dose escalation, because those are still very topical. I'm going to go on a favorite topic of mine, which is drug and radiotherapy combinations, which I think we all must be increasingly aware of in our sphere of radiation oncology, and then to think of some future directions in radiation oncology. So back to defining the stage 3, and what exactly is it? Well, if you kind of look here in these cartoons, these define stage 3A, stage 3B, stage 3 in the most recent 8th classification of lung cancer staging. And that's constantly evolving. And although the 9th classification isn't already published, the International Staging Consensus is actually working on the 10th staging classification. So this, again, evolves quite rapidly over time, roughly every 5 to 10 years. If you look at this cartoon down here, green is stage 1. The orange, that little tiny bit there, is stage 2. That yellow bit is stage 2. All the blue is stage 3, and of course the purple and pink is stage 4. So stage 3 occupies quite a lot of the TNM classic descriptors of lung cancer, and it's quite a heterogeneous group of cancers, everything from a small T1 tumor with N2 nodes to a very large advanced T4 tumor with N3 nodes. And as you can already guess and imagine, there's a lot of heterogeneity both in how you might approach treating those cancers as well as the outcomes of those cancers. So needless to say, the outcome for a localized T4N0 is probably a lot better than that for a T4N3 disease. So it's a very heterogeneous group in terms of staging within lung cancer itself. Also, in lung cancer, the patient population that we get for consideration of therapy for treatment in stage 3 lung cancer is very heterogeneous in terms of their ability to undergo, receive, and safely get through treatment. And I've just put a few illustrative cartoons that age alone is not a good descriptor, and there's a lot of work on how you functionally assess a patient for treatment in the workup for a lung cancer treatment. We think of cardiopulmonary reserve, and one way to measure that is by various lung function measures, a cardiopulmonary exercise stress test, also known as CPES test, and even simple measurements such as, say, a stair test. So roughly speaking, if you can walk up 6 flights of stairs, you should be roughly suitable for a lobectomy and certainly fit enough for radical radiation. But certainly appearances do deceive, and as you can see, we very often get some very fit, octogenarians who can very safely receive radiotherapy. But one thing to say is that chemotherapy delivery in the 80s and 90s is very challenging, and patients, regardless of their fitness, are much more likely to have systemic therapy complications. And of course, one complicating factor in lung cancer is that owing to the very common etiology, though it's not universal, of smoking being a common etiology of lung cancer, unfortunately, patients with lung cancer have other comorbidities such as cardiovascular health disease and COPD, which again limit our ability to undergo a treatment. So there's nothing like a good functional assessment in person when you're considering somebody for radical radiation treatment. Now, there's a degree of variation staging, also in patients, and then in the actual pathology of non-small cell lung cancer, what we classified previously as one disease is a very large heterogeneous group of diseases. And we kind of subdivided it 15 years ago into squamous cell carcinoma or adenocarcinoma, but that again has been subdivided and subdivided and subdivided yet again. And we now think about the molecular diagnosis of lung cancer. So if it's an adenocarcinoma, is it EGFR positive, is it ALK positive, what other mutations are there that might be driving this particular non-small cell lung cancer? I'll explain later how they've come into some of the treatment paradigms, so to speak. Also, in the immunotherapy era, we're now testing tumors for markers expression, and the commonly used one at the moment is PD-L1 expression. That's PD-L1 is the signaling thing between a tumor cell and the T cells itself, that you tell how that interaction happens, that starts an immune reaction, and we can test the receptor. It's not by any means the best test, but it's the one we commonly use to say whether a tumor might likely respond to immunotherapy. So again, molecular diagnosis is certainly an issue. Of course, and then when we think of stage 3 non-small cell lung cancer, I'll come back to this later, we have to think about whether this can be resected by a surgeon or whether this cannot be resected. And that definition of resectability is ever-changing and is very hard to pin down. Very hard to pin down for surgeons to pin down, and certainly very hard for external observers to say what is resectable and what isn't resectable. And I'll speak a little bit about that later too as well. Of course, here now is some guidance, and this has come from a very good piece of work led by Mariana Brando, and this is an ERTC group which was presented at the World Congress Lung Cancer last year. This looked at trying to define and nail down that definition of resectability, because that definition then determines what treatment pathway we might likely go through. So they did a very good systematic review, did an international survey, did some cases discussion, and this all led up to quite a comprehensive Delphi process and tried to get consensus where this was possible. And this included quite a large number of all the key lung cancer groups internationally too as well. So in their consensus definition, the first thing that they said is what must you have when you are working, what basic investigations must a patient undergo when they're being worked up for consideration of treatment in stage 3 non-small cell. And they quite rightly said you need a contrast-enhanced chest CT scan. You also need a PET CT scan, and that must be within a timely manner. You should have a brain imaging, preferably a brain MRI, and you should have some form of nodal staging, be that EBUS or mediastinoscopy. And then additional tests may be required if a suspicion of invasion into neighboring structures. And what we mean by that is, say, for instance, you might be concerned about invasion of the spinal cord. You may wish also to get an MRI of the spine to assess that spine to see is it involved by tumor or not. So that I see are the key workups in terms of deciding the stage of the tumour. Of course, there'll be all the functional workup too as well. Then who should be involved in making a decision about operability or treatment decisions? And they said in that multidisciplinary treating consideration that you'd need a thoracic surgeon, radiation oncologist, a medical oncologist, pulmonologist, an imaging specialist such as a radiologist, and a pathologist, and ideally also a lung cancer specialist nurse or indeed specialist radiation therapist too as well. And I think this particular consensus is very helpful, saying what is the minimum that we absolutely need to make that decision. So considering resectability, because again, in terms of doing radiation, what is resectable? And this took a little bit of work apparently, but got there in the end. But what's not resectable clearly is your heart. Very hard to do without your heart. Your trachea. There was some, as you may remember, a very infamous case of using a tracheal reconstruction, but that hasn't, of course, borne fruit. Your esophagus is not classically resectable in lung cancer, and neither is your spinal cord. But all these other structures are potentially resectable, and this is where the kind of the challenges in saying what is resectable and what is not. So they took these, they put them into a table, and if this is kind of looking across the panacea of stage 3, all stages, and you look here that obviously very early stage disease, say T4N0 is clearly resectable and should generally be resectable, provided it's not invading something that's not, such as the heart and so on. And whilst you go up to things that are single station N1 is potentially resectable, get to multi-station N2 disease, there is the challenge in disease, what can be taken away, clearly or not. And of course, if you've got bulky N2 disease, that's classically thought to be unresectable disease in stage 3, and N3 is definitely unresectable too as well. And I think this is a very good table that informs a lot of discussions now in MDT meetings. The challenge, of course, is that yellow bit in the middle in saying what's resectable and what isn't. Also, to step back a bit, we need to also think in our descriptors of what we're dealing with in stage 3 non-small cell lung cancer. Think of our nodal stations. And this really hasn't changed much. This is classic nodal staging atlas, which we use quite commonly to say what node groups are involved and which aren't. And that also helps staging, helps us also define our radiotherapy target volumes conceptually in our head. Helps us work out what's encompassable, so to speak, in a radical plan. And we've got a lot better at saying what's encompassable or not, but at an MDT, it's still very hard when you eyeball a tumor in a PET scan to say, can I actually treat this or can I not? And it really only comes out in the wash when you undergo radiotherapy planning as to whether you can actually bring that person successfully through radiation therapy. So what are indications for using radiation in stage 3 non-small cell? And I'm going to give you a very boring slide here, but this probably gives you a very good summary of what I think are the key indications for treatment in non-small cell lung cancer. Of course, there's using radical radiotherapy alone, and that's just using something such as 60 Gray in 30 fractions, or commonly 55 Gray in 20 fractions as the radical definitive treatment alone. We also use radiation radically with concurrent chemotherapy, and that is, I think, the gold standard, and we'll explain why later on in stage 3 non-small cell lung cancer. We also use radiotherapy following induction or indeed neoadjuvant chemotherapy, where a person has had chemotherapy first and they go on to have a radical radiation. And not to forget that in stage 3, when a patient isn't fit enough or has other comorbidities or there are other factors, that we may consider using palliative radiation for symptom control, or indeed high-dose palliation to try and give some modest, life extension, though the evidence that is certainly not as strong for that indication. If I go to adjuvant therapy, and this is classically after surgery of one form or another, when might we use radiation? Well, there was certainly a lot of vogue, certainly back 20, 30 years ago for using post-operative radiotherapy for high-risk disease. That's N2 positive disease. That has fallen away, and I'll explain why in just a few slides. The other indication for adjuvant therapy, so to speak, although it's not truly adjuvant, is to use adjuvant therapy where a patient has had an incomplete surgical resection. In other words, has had a positive margin. So there is the concern that because of the positive margin, there are cancer cells or viable disease left behind at the surgical margin. And in good surgical practice, the surgeon will very clearly know where the clips are. They'll be able to explain to you where you need to treat in that particular setting. Sometimes radiotherapy is used neoadjuvantly, either as part of trimodality therapy. And the classic example here is in a pancreas tumor, where we sometimes use chemoradiation prior to surgical resection. And we either use radiation alone, or indeed, as induction chemoradiotherapy. Trimodality therapy on its own is very popular in certain European centres, but is not really widely used internationally outside of that, and I'll not really cover that much in this particular webinar. And one other thing not to forget is that increasingly we are seeing patients who've had prior radical radiotherapy who have had recurrence either in the tumour bed or indeed in the local regional area, and we're commonly being asked to consider re-irradiation following prior radiotherapy. So I would see those as our key indications for radiotherapy in stage 3 non-small cell lung cancer. And if we go back here, that whole question of surgery versus radiotherapy, what is our kind of key evidence? This is one of the key papers that people very often quote. It's actually a trial of induction chemotherapy, and then patients were either randomized to receive radiation alone or indeed surgery and possible post-operative radiotherapy if that was indicated. And in this particular older study, there was no overall survival difference between those who'd received radiation following chemotherapy compared to those who had surgery in stage 3 non-small cell. So we're saying that this gives a lot of ground to use of radiation in stage 3. If I switch gears then to the post-operative adjuvant setting, we had the PORT meta-analysis way back in 1999, and that raised a concern that people who had post-operative adjuvant radiotherapy as a kind of routine or for high-risk settings such as N2 disease, and this is not in the incomplete resected, this is the completely resected population, that those patients had an increased risk of mortality. And this led on to Cecilia Pichot and others setting up what was called the Lung Art Study. This study, and we were involved in Belfast, took a long while to accrue. It was quite a complicated study in some regards, but it was a very niche setting and a lot of confiners. The one really brilliant thing this study does was standardized how we planned and approached the radiotherapy treatment of patients who you might consider a post-operative radiotherapy in. So in this group, patients who had completely resected non-small cell lung cancer, who had N2 disease, were randomized to follow-up alone or conformal radiation with a dose of 54 gray in 27 or 30 fractions. And whilst in this study, post-operative radiotherapy, as you can see here by the red line, had an increased chance of disease-free survival compared to no radiotherapy, and the mediastinal relapse was significantly reduced by 4 to 25% compared to the control. The other rate of other metastases, such as say brain metastases, was increased, and there was an increased risk of death, though all these were non-significant, as was the slight difference in disease-free survival. And really following this trial, the use of post-operative radiotherapy for N2 disease has fallen away entirely in this group of patients, and it is not widely practiced. So no different overall survival, and really we reserve usage for positive margin disease and incomplete resection. So if we swing back and say we're going to undertake radical radiation for stage 3 non-small cell lung cancer, how might you deliver this radiation and what techniques might you use? Well, if you go back a little bit and say, why do we fail radiotherapy? And we fail either because we've missed the target, or we may have radiation resistance, we missed the target. How can we overcome that geographic miss? And that really describes what we consider in terms of our improvements in radiation. So if we start first of all back at staging, this is the classic staging paper in non-small cell lung cancer from Michael McManus and colleagues in the Peter Mac in Melbourne, and they clearly showed that if patients who had a PET staging as part of their workup had a better chance of surviving than those who had no PET CT as part of the staging. So PET CT is now a standard imaging technique, both in the staging and also in radiotherapy planning. Taking that forward, we investigated the role of using PET-based images to undertake radiotherapy planning. And as you can see, if you look at this example here on the left, you can see the tumor here nicely in the PET scan. And this is classical atelectasis, the sale sign on CT, but it's very hard to say on the CT where the tumor ends and where the atelectasis starts, but the PET clearly shows it. And that allows you to be more precise on your target volumes. And this is one of the reasons for using PET in radiotherapy planning. We we then went on to generate an IEA consensus report that described how you might combine both of the imaging techniques. And this is just another example of using PET to try and say where active begins and ends in that setting. So people have looked at this and they said maybe you can go on and boost that, and there's been a number of studies, including this particular one by Ursula and essay, looking at maybe should we use PET alone for planning? Should we not? This study looked at elective nodal radiation versus PET-based radiation, PET-based nodal delineation, and in this study, Ursula and colleagues clearly showed that conventional target delineation had an increased risk of relapse perversely compared to that which was PET-based. The PET-based is more accurate, and interestingly, there's no difference in side effects, which one would have expected in a way. Moving on to motion management, this lovely old paper that's showing the range of motion management. Of course, tumours at the base of the lungs move more than at the top of the lungs. We also know that lymph nodes move more, or move sometimes in paradoxical manner compared to the primary tumour. So motion is very important to describe and capture. And of course, the gold standard now is using 4D CT scanning to capture all of that particular tumour motion as a patient breathes out. And I think that to me is an absolute must now going forward. Of course, why do we use it? One is we know exactly where the motion is, so we're more accurate. It also allows us to adapt our margins to perhaps avoid, avoid those areas that are critical parts of a patient. So esophagus, for instance, is one. Reducing lung volumes, that reduces that risk, hopefully, of toxicity. This was some work we did in Belfast way back. I think also key to the radiotherapy delivery technique is image guidance, and I think now volumetric-based image guidance with cone beam CT is an absolute standard of care. And you can see here's a tumour here at baseline planning, and do the first cone beam CT, and this is every radiation oncologist's heart sink moment where you see the tumour unfortunately has progressed, and not only has it progressed, that's a bad thing, but of course the work of undergoing replanning. But this at least knows that at least cone beam informs us of that. And I think I look back to 10 years ago, we weren't using cone beam CT regularly, and think of probably the 1 in 10 patients who had this, and we simply couldn't detect this, and we were giving them probably a futile treatment as a result of that. So certainly I think cone beam CT again is another very key benefit. I think key bit is how the radiation oncologist approaches or undertakes radiotherapy planning. I kind of put this slide up years ago. This is the 7 deadly sins of local regional relapse, and you could talk about all of these, but to me the greatest sin is to miss the tumour entirely. And this is where quality assurance around our target volume delineation is absolutely key in radiation oncology. And we know this has been known for many years, that when you ask a bunch of radiation oncologists to outline a tumour, they all do something entirely different. And this is a lovely old French study. The RD is radiologists, RT is radiation oncology, and J is junior, and S is senior. And what it seems to be is that the more senior you are, and if you're a radiation oncologist, you tend to draw larger volumes than compared if you're junior. So in other words, sadly, as you've seen many failures in lung cancer, you tend to be much more cautious and include larger margins, so to speak, to delineate a tumour. So inter-observation is certainly a thing, and it does hamper what we do in radiation oncology. And when people bring in peer review, so peer review is where you get a second check by another radiation oncologist, or indeed team of radiation oncologists, also described as chart rounds elsewhere. When you implement that, significant proportions of radiotherapy plans or target volume delineations are changed because of that peer review. And this is a lovely summary by Kelly Brunchkill from Canada. And this looks at the rate of treatment change plans. And some series is as high as 100%. But of course, the question is how big were the changes? In our own series in Belfast, we saw that about 27% in lung cancer were changed following peer review. And we implemented that a number of years, and we found that that has certainly upticked our outcome for us. Perhaps the best evidence is not in lung cancer. This is the very well-known TROG0202 study led by Lester Peters and colleagues. And this looked at if you, in a head and neck clinical trial, that if the target volumes were compliant with the protocol at the very start, these patients had the best outcome. If they had been made compliant, that also brought the outcomes up. But if they had had a non-compliant plan, then their outcomes were a lot less, both in local regional survival, as you expect, and overall survival. So peer review really does have a significant impact on radiotherapy treatment planning, and it's probably the most important thing that we need to improve on over time. And this, of course, comically is our approach to peer review. In other words, we're all in this together. So it helps sharpen the pencil, so to speak. The Royal College of Radiologists in the UK have been working this as the second edition, which we're involved in, again, saying how might you approach peer review, how might you do this in a systematic way, and they provide really good guidance about how to undertake peer review in a very methodical, thoughtful way that is supportive, that improves quality of care, and also, helps bring a team together in a very open and learning manner. So if you haven't come across this, I would commend you to consider this peer review. But I think this is key to what we do in stage 3 non-small cell. Then think of the techniques or the ability to deliver radiation in a different way. It's quite a nice analysis by Joe Chang and formerly Jim Cox, MD Anderson. This looked at 3D conformal versus IMRT versus protons. You can see that dosimetrically, clearly protons look much more superior for complicated lung cancers, and IMRT certainly looks better than 3D conformal radiation. One thing that I would say is that sometimes when we're particularly using VMAT or ARC type therapies, that does increase the low dose bath of dose around the lungs. We used to think that was quite significant, that may be less of the case than thought previously. But certainly is one thing to consider. Sometimes a fixed field IMRT may reduce the overall and certainly the low dose lung bath. But looking at these images, you'd immediately think that why would we not immediately go to proton therapy? And that's certainly a very reasonable consideration. Sadly, the only randomized or quasi-randomized evidence that we have is from this particular paper published now 6 years ago in Journal of Clinical Oncology. This compared IMRT versus proton therapy. There were some confounders regarding the eligibility of patients for proton therapy vis-a-vis their insurance status, and that probably limited the trial a little bit. But in this study, there was no difference in local failure or indeed regional progression or indeed pneumonitis rates. There's none of those key differences, both the side effects or indeed clinical outcomes between proton therapy and IMRT. And this might be because we've optimized IMRT and VMAT delivery quite significantly over the last 15, 20 years, and it may take a while for proton therapy to catch up. It also suggests that it is very hard, very often, to try and show these very small marginal differences in what we deliver in radiation quality to actually show that that actually matters to a patient population. That makes it very challenging for us to gather the evidence and to justify improvements in our techniques or treatments. One thing I would say for protons is there's increasing enthusiasm for use of proton therapy in non-small cell lung cancer in consideration of re-irradiation, where you really want to reduce the dose to normal structures that have had a previous, near tolerance radiation dose. So it is all about marginal gains, and this, of course, is the Sky cycling team, and they, of course, sweat the small stuff. The theory is you keep working with the margins, you, of course, slowly improve outcomes, particularly in lung cancer. So on to a big topic of altered fractionation and dose escalation in non-small cell lung cancer, which has really been quite a big topic discussion over the last number of years. Of course, there are 5 classic R's of radiation biology. I heard recently there may be up to 7, depending on how you describe those, but of course the 5 are repair, reassortment, repopulation, reoxygenation, and radiosensitivity, all of which are impacted by the dose of radiation and the schedule used to deliver radiation. Hyperfractionation, of course, was one thing that folks thought might be very useful to prolong treatment time and to give that therapeutic ratio improvement between normal tissues and tumor tissues. Of course, the theory being is that in hyperfractionation, by reducing the overall dose per fraction but breaking up into smaller doses, you give time for the normal tissues to recover. But the huge downside is this prolongs the treatment time. And we know that in lung cancer, the length of treatment time between this first fraction and the last fraction really, really matters. If you look at these curves from the Red Journal, here is standard radiation in black, prolonged radiation in red, and there you can see there's quite a significant survival difference between these two particular arms. And you can see that it described in a different way there. So time really matters in non-small cell. That's why we consider it as a category 1 tumor. We try and avoid anything that we have compensatory gap days where there are, breaks in treatment and so on. So, yeah, head spins, but yes, you do want to, therefore, hyperfractionation might be good, but you want to combine hyperfractionation with acceleration to, of course, reduce the overall treatment time. And I, of course, comically use this example of the DeLorean car, of course, which was made in Belfast, to say, look, we really need to kind of speed up a little bit in our treatment. So combining both hyperfractionation and also acceleration was the CHART study. And this was a very seminal study from the UK, led by Stanley Dish and Michelle Saunders, and published actually over now, 25 years ago. And what this did, this took patients with head and neck and non-small cell lung cancer. I'm just going to show you the lung cancer curves here, but took those patients and it randomized them to standard radiotherapy compared to CHART. And CHART was giving 54 gray 3 times daily in 12 consecutive days, including over the weekend. And this logistically was very challenging to deliver, simply because, if you had to have at least a 6-hour break between fractions, which meant you were treating patients very early in the day, usually towards the afternoon, and then sometime around about midnight to try and get it in. That was for 12 consecutive days, including weekends. And you can imagine there weren't too many people signing up to do the 12 o'clock treatment delivery on a Saturday or indeed Sunday night, and this was one of the challenges. But needless to say, this did in lung cancer have a very big uptick, relatively speaking, in survival, and also that was driven not by distant control but also by local control. There was a little uptick in esophagitis and also a little uptick in early pneumonitis, but not in late pneumonitis, as you would expect from early responding tissues. So problem is, of course, the weekends, and we all do like to enjoy weekends, or certainly days off during the week. And with that, the thought was considered, maybe if we could do CHART, but just take the weekends off, might that be okay? And of course it isn't. And here is CHARTwell, which give CHARTs type radiotherapy Monday to Friday, but actually then give standard radiation, compared to standard radiation. Of course, there was no improvement over standard radiation, unfortunately. So if you're going to do CHART, which does improve outcomes, you have to do it over the weekend too as well. And the reason this failure is probably there might be in that break over the weekend an accelerated repopulation or indeed reassortment in the cell cycle of the weekend that may cause or drive that lack of improvement compared to CHART alone. So people have looked at this. I really like this meta-analysis. It's a little old now. It's over 10 years old, and this looked at all sorts of confounding factors such as treatment time and other factors. But what they clearly showed was that there is, when you look at all the studies that have published on altered fractionation, that certainly very accelerated radiotherapy certainly seems to have a clinical benefit to patients in terms of overall survival. And that's again across the group too as well. And you see this also in this Kaplan-Meier plot. You can see the modified radiotherapy compared to eventual certainly has at least a couple of % gain at 5 years in overall survival. So it is certainly worthwhile doing. That doesn't seem much, but in that absolute terms of improving 8 to 10, treat 100 patients, 2 more are alive because you've done altered fractionation. We, myself and led by Corinne Fryn and others, looked at this in the UK's isotoxic IMRT study, where we threw the whole book at patients, hyperfractionated, escalating the dose up to that which could be tolerated by the normal tissues, doing all image guidance that you possibly could do, and see did this make a difference. This was feasible, and we actually got up to max dose of 79.2 grays safely with that. And we were going to take that forward into a further study, but unfortunately that kind of ran aground a little bit with COVID, but worthwhile saying that we had quite good survival with this particular approach. But we did have some treatment-related toxicity with acute pneumonitis and 1 bronchopulmonary hemorrhage at a year time point. And of course, this gives concern about dose escalation, which we'll come back to in a little second. So when we look at dose escalation, this has been on the go for a long period of time, and I want to share this, but this is from 1995 from Mary Graham, and Mary Graham is the key author, a key researcher who gave us the V20 lung parameter, which we use classically all the time now the planned radiation. But this was a different study where they looked at a dose escalation, giving 2.68 gray once daily in 28 fractions over 5.5 weeks, about 75 gray. They did use elective nodal radiation, but these are very good outcomes in terms of being 25% being alive 2 years with radiation alone back in the day. But there was, again, some late sequelae and pulmonary fibrosis, necrosis. These are things that they saw with this patient group. So even back then, when dose escalation was used, seemed to perhaps improve local control, but at the price, of course, of toxicity. And again, this is another early phase study, CAL-GB 39904, and this looked at keeping the total dose the same, but changing the fraction size and altering the number of fractionation, and therefore reduced the treatment time. And they did show, again, good outcomes for the patient group, but this, this hasn't really gone well in later phase studies. And again, here's another similar study. This is now looking at keeping the number of fractions the same, but increasing the dose per fraction. And by doing that, increasing the total overall dose from roughly 60 gray up to 85.5 gray. And they didn't see any difference, but they did see, again, significant grade 3 or grade 4 or grade 5 toxicity. And again, that dose escalation comes with the price of normal tissue toxicity. Worth saying that in the UK, hyperfractionated radiotherapy has been a standard for many years, particularly in the north of England. And there, in stage 3 non-small cell lung cancer, a standard dosage very often given is 55 gray and 20 fraction over 4 weeks. And I think this has been adopted quite significantly internationally, particularly if you're delivering radiation alone in that setting. But what about giving that 55 gray and 20 fractions over 4 weeks? Well, this is the UK soccer study, and this looked at giving concurrent versus sequential vinorelbine cisplatin chemotherapy alongside 55 gray and 20 fractions. And the outcomes were actually very good in this study. But there was, again, a little uptake in toxicity. But this is, if you look here at the 24-year survival, it's roughly about 50%. And that was actually quite good. And this led to adoption of this regime, although it wasn't truly randomized comparison of standard fractionation versus 55 gray and 20 fractions. So that's been used quite internationally, but I think people are moved back a little bit because there has been concern from this recent analysis by Mike Brada et al. Looking at 55 gray versus the standard regime, suggests that it might be slightly lower survival, and this could be confounded by other factors such as patient selection in this very large data set. So, dose escalation, where did we get to? And of course, the classic study, and unless you've been living under a stone in lung cancer, you'll have heard of RTOG 0617. And this large North American study randomized patients to either 60 gray in 30 fractions or 74 gray in 2 gray per fraction, and a secondary randomization to carboplatin paclitaxel plus or minus tuximab. So it's a 2x2 factorial design. And as you can see from this overall survival plot, you can see that 60 gray does much better compared to 74 gray. And this, at the time, was heartbreaking for most radiation oncologists who were passionately, believers in dose escalation, as I was at that point in time, that more must be better, and it clearly wasn't. And why was it not better? And with a lot of reasons for that, possibly. Maybe the biology impacts it. But I think one of the key things that's coming out of this study is the fact that when you look at this, it's clear that when you do the subset analysis, that patients who had higher normal tissue doses, because of the increased dose escalation, did a lot worse than others. One key bit is not just the lung toxicity, but also heart. And here is overall survival by heart V40 gray. So if your V40 is high, it's this red line. If your V40 is low, it's the blue line. And you can see there's quite a significant separation in those curves that might be driving this poor outcome of dose escalation. So dose escalation on its own, without consideration to the normal tissue constraints, is not a reasonable investigational strategy at this point in time. This also interestingly showed that, and this is probably the best evidence for using IMRT in lung cancer, is that if you used IMRT compared to 3D conformal radiation, as was permitted in the study, that there was a significant reduction in clinically significant pneumonitis, which was defined as a grade 3 or greater adverse event. And to me, this actually gives the best evidence, although of course it is not randomized for these radiation. This is a little bit of work on cardiac substructures. There's a lot of, we talk about the base of the heart, maybe coronary ostia, coronary vessels, but it's a little bit of work that's emerging by one of our fellows, Jared Walls, based in Belfast now, currently Christie, and he's been looking at the pulmonary vein and saying, is the pulmonary vein a constraint of concern? And actually it turns out it may well be, particularly for the induction or generation of cardiac arrhythmias. And so the higher your pulmonary vein dose, the higher arrhythmias. Of course, what do you do about this? And this might be one of the challenges. How do we avoid these structures too as well? One other thought is when you're if you're thinking about dose escalation, perhaps maybe that, as well as considering the normal tissues, might you use, advanced imaging techniques such as PET to say if there's very avid or very high uptake of the PET signal in certain parts of the tumor, might that be an area you want to boost or give a higher dose of radiation and maybe not all of the tumor? This is the PET boost study, led by a European Dutch consortium, and this looked at either boosting the area that was PET positive versus not boosting it, and they randomized 107 patients, and really there was no difference in outcome. There was an increased risk of grade 5 events in both arms, but there really hasn't been any demonstrable benefit. There has been another more recent PET boosted study presented at ESTRA this year, and it did show a benefit, though there were other confounders around that. So dose escalation is challenging, and it may not be the way to go, particularly in stage 3 non-small cell lung cancer, and we haven't yet shown a strategy that clearly shows a benefit for dose escalation in that way. And again, this is our comparison of IMRT and photons. So how might we better improve what we do in radiation? And drug and radiotherapy combination is one way to go. This is the very old Dillman study, which showed that sequential cisplatin and blasting before radiation improved outcomes. You can see that curve there. This is the classical upward meta-analysis, which if you look at 5 years, the blue line is induction chemotherapy and radiotherapy. Yellow line is concurrent chemotherapy and radiotherapy, and there's an absolute benefit of 5% by giving concurrent chemotherapy rather than induction. This is very important, and particularly at the moment in MDT decision making. If you're given induction therapy and you can't get the surgery, then you've missed the chance to have concurrent chemoradiation, and there may be a penalty to pay for patients in outcome. So of course, the slight downside is there's a slight increased risk in esophageal toxicity with concurrent versus induction. What about the type of chemotherapy? This is a PROCLAIM study. This is looking at tailoring the type of chemotherapy to cell type concurrently. This didn't show any difference, unfortunately. There may be other reasons such as mutational status as driving this confounding result. Of course, the big name in town is specific study. This is giving adjuvant immunotherapy in the form of durvalumab after successfully completing chemoradiation. And you can see here, there's a very big gain in 4-year survival. And a 4-year survival here is absolutely stonking at 50%. We've never seen this before in stage 3 non-small cell lung cancer, although we have selected those patients in the study who've completed chemoradiation, so a better patient group in any case. But certainly, there's an impact of durvalumab in all patients. Moving on, more recently, just presented at ASCO, was the LAURA study. And this randomized patients, again, who completed chemoradiation, who are now EGFR mutation positive, to receive adjuvant osimertinib for 3 years versus placebo. And there's a very big difference here in progression-free survival. Note of caution, this is not overall survival, and there are a lot of considerations around this particular study. But again, this is showing the direction of travel in tailoring personalized medicine. So where to next? Well, we continue to evolve radiation therapy, and as you can see, we've got all these technical developments over the period of time, and we're certainly beginning to reach a plateau in what we're technically being able to do and improve. Though that just shouldn't stop us, but certainly it is now in that marginal gains part in terms of how we improve. So might we improve our radiation by adding other stuff too? And again, I've mentioned drug and radiotherapy combinations. There's a fantastic consensus paper out of the UK, and there have been a number of considerations at very high levels with ASTRO, AACR, the US FDA, but how better might we combine drug and radiotherapy combinations? So in the UK, we thought about it, if we stood back and said, what are the hallmarks of cancer and where are these hallmarks important? How might we combine these? Where might these combine best? And what drugs might we consider for radiation? And one of the groups we looked at has been looking at these, DNA damage repair inhibitors around that genomic instability and mutation part of cancer. And just to show an example, this has led on to the Concord study, which I was involved in setting up before in Australia, and now led by Corinne Favrafin and Alistair Greystoke. Now, When we were thinking of drugs for this, again, we thought about those drugs that were involved in the DNA damage repair mechanism and how might this augment the effect of radiation damage in the tumor compared to the normal tissues. And this is looking at an ATR inhibitor, some work, preclinical work we did in murine models in Belfast. The pink line here is the drug and radiation. If you look here, the radiation alone are these other lines or the drug lines, and you clearly can see that separation of the curves, particularly out here in tumor volume when you give the drug and radiotherapy together. We also looked at the drug effect in normal tissue and looking at how best might we give that in terms of enhancement of lung tissue. And this particular drug didn't cause any enhancement in radiation damage in lung tissue, which made it a very good candidate for taking forward into the study. And the study looks like this. The Concord study is a platform study. Platform studies are being increasingly used to bring complex therapies into cancer treatment. Because what they do is they set up the structure of a trial, and you can change the drugs, you can add arms in and out of these platform studies, keep the trial going as the technology or indeed the pharmacology evolves. And the Concord study is open across a number of centres in the UK, and it compares radiotherapy and the drug combination versus radiotherapy alone, and we look at a number of different outputs. And if you're interested, this is the Twitter feed handle for Concord if you want to follow updates from that particular study. So inroads immunotherapy, and of course it's been the game changer across oncology, particularly the last 10 years. And in particular, this is impacting the stage 3 non-small cell lung cancer, whereby there are a number of brilliant studies which are looked at either preoperative immunotherapy or chemoimmunotherapy, as well as preoperative and postoperative chemoimmunotherapy. And this is one example. This is the Checkmate 77T study. Some results were presented at the ELCC Congress earlier this year. And this looks at giving, induction chemotherapy and immunotherapy, followed by surgery, followed by immunotherapy for a year. And there are really some fantastic, outcomes. This is event-free survival. And this is the immunotherapy arm, the chemotherapy arm. You can see a clear improvement in that particular parameter for these group of patients. And we look at all the IO studies. This is a range of the different studies. So Checkmate 816 is a very seminal study led by Patrick Ford. We've got Empower, Keynote, and of course the GN and Checkmate. And these are all looking at forms of immunotherapy around surgery. And what this has done in stage 3, this has actually kind of increased enthusiasm for a surgical approach to stage 3 compared to using radiation. That might be good and proper, but we don't want, again, patients who are not suitable for surgical resection missing out on the opportunity to have concurrent chemoradiation followed by adjuvant durvalumab, if that's indeed appropriate. So this was a slide we put together about 5 years ago, and this is very simple. It was actually very straightforward, but this has now become a very complicated treatment paradigm. We haven't yet worked out what the right paradigm is around the management of stage 3 non-small cell lung cancer in that bit of surgery versus radiotherapy. So it's turned on its head yet again, and I'm sure it will continue to change and evolve. So I almost kind of comically put up this slide. One of my favorite songs, Video Kill the Radio Star, and of course immuno in this slide kills the unfortunate radio star. So radiation, how might we do better? Well, we need a precision approach. There's a lovely paper here by Norman Coleman, lovely picture in the Red Journal, in this week's edition of the Red Journal. Really commend you to read it. Norman's a really fantastic person, but he really put out a clarion call to all of us to say we must have a better precision medicine based approach to radiation. That simply, fractionation A versus fractionation B will not cut it in our future studies. But you say, Gerry, isn't radiotherapy really precision medicine? Yes, it is, but we need to think of precision medicine around particularly biology approaches around that. If you go to breast cancer, there's already use of gene-based or other forms of analytic panels that can say, this patient may benefit more from radiation in a certain setting. This is, of course, the Oncotype DX-DICS score. In our analysis earlier, where we looked at that bit about the ATR inhibitor leading to the Concord, so that we could clearly show that certain mutations, such as this is P10 mutations, predicted for the response of radiotherapy and the ATR inhibitor together. So I think we're going to move more towards a precision medicine-based approach in this setting. Also about how might we optimize cardiac events, how might we look at that, are there predictors for that we might put more priority onto avoiding dose going to the heart. Also, new technologies such as circulating tumor DNA. This is where there's a tumor cell, the tumor breaks up, little fragments of the DNA come out in the blood, they circulate around. You can pick these up in certain types of analysis. You might also pick up some of the organs at risk DNA that comes out too as well. And what might you do with it? Well, you could use it, for molecular response. You could say, could I use this to predict response to a tablet? Could I look at the resistance pattern? Or can I use it to follow somebody up and say, have they relapsed or not? So there's a lot of different avenues for that. But one thing is clear, that when you deliver radiation, you cause this massive release owing to apoptosis of circulating tumor DNA. So radiation, circulating tumor DNA during treatment might be an interesting avenue to explore. So that's one further one. This is a little bit of work that, again, Gerry and I and others in Belfast did previously, looking at the change in circulating tumor DNA patterns as you go through treatment. And what is very clear, there seems to be a spike in the early days following radiotherapy treatment. Couldn't do a seminar from Trinity and not mention radiomics. Of course, a lot of work done here by Michelle and others, Liz Ford, on the use of radiomics. Radiomics is using image-based analysis, looking at features out and saying, can you predict a signature? Now, it's been a bit of a black box until recently, but actually there's been some interesting work published showing that, particularly looking at chemoradiotherapy and immunotherapy combinations, that radiomics seem to be able to predict for those who respond and not. And I think there'll be a lot of work analysis on this in the future. Very finally, this is again looking at a different precision medicine approach. This is an immunotherapy PET study from Peter Mack, which is actually looking at immune imaging using a durvalumab-based tracer in lung cancer. This is showing a patient scan where you can see uptake of the durvalumab inside the spine, which you don't see in the ordinary PET scan. Again, this might help predict those who respond to immune radiotherapy combinations. So lots of different avenues we may consider in how we improve lung cancer radiotherapy. Very finally, again, this is again work done by Peter Mack, looking at nodal staging. This is the seismic study, which shows if you do a much more complete EBUS type staging than mediastinum, that improves our radiotherapy target volume. So even though we think PET is brilliant, there's ways we can continuously improve the treatment that we do. So we need to think about precision medicine, drug radiotherapy combinations, normal tissue approaches, tumor responses, and of course, biology-based approaches. Very finally, radiotherapy still remains a key modality in the treatment of stage 3 non-small cell lung cancer. Certainly, the standard of care is to use the best baseline staging imaging, such as PET, EBUS, and so on, 4D CT for planning, IMRT planned, VMAT planned, and cone beam CT delivered at the very least. For classical stage 3 non-small cell lung cancer that's inoperable, chemoradiotherapy remains the gold standard, followed by durvalumab if that patient is PD-L1 positive. Radiotherapy dose escalation doesn't appear to be helpful with our current technologies, but may improve once we work out how best to do that in a different way. There's a growing use of novel systemic therapy combinations, both concurrently and adjuvantly, and we need better tools to select patients for therapy and also better tools to deliver a personalized medicine approach. Thank you very much.
Thank you, Gerry. Thank you for that tour de force and I suppose, overview of a very vast topic. It's hard to bring it down into 1 hour webinar. I feel like you could do a webinar on a lot of those topics individually. So I'd just like to invite any participants to add questions to the Q&A. Also, we have one through already. So what is the place of RT in the re-irradiation setting? So do you think you're seeing a rise in eligible cases at the minute, or how do you feel about that?
Yes, it's a really good question. So classically, if I roll back, say, 10, 20 years, when somebody had say, definitive radiation for treatment of a lung cancer, and they then had local or local regional recurrence, we classically said we cannot repeat this treatment. That was our classic, standpoint or message out to, colleagues and to the patients themselves, of course, ultimately. But what we have learned now is that we can significantly deliver radiotherapy again, provided we are absolutely clear on observing and respecting normal tissue constraints. So there's a lot of work going on to say what are those constraints, and there's been quite a large consortium led out of Canada and also out of Glasgow looking at re-irradiation and what might the constraints be, and a very large Delphi analysis published roughly about 3 years ago, giving some sense of what might your constraints be. And those constraints are generally described in BED doses because obviously you want to do that per tissue, and you're trying to combine sometimes 2 different fractionation regimes. One of the challenges around that is actually looking at old imaging, how a patient may have changed, they may have lost weight, they may be slightly deformed, the lungs may have moved around post-treatment, and how do you actually match up the prior treatment scan with a current treatment scan. And if you use tools such as the formal registration, do those tools accurately describe what that cumulative dose is to the normal tissue structures? So we're getting there. We're using a lot more often than we did do previously. I'm getting a lot more confident delivering. I think one thing to say is we've been absolutely paranoid, quite rightly, to say, we don't want to cause any extra suffering or morbidity patients really have, and therefore we've been absolutely right at respecting normal tissue constraints and being normal tissues in that way, but perhaps we've been overly cautious. Cancer itself, is a fatal disease universally, and if we don't control that cancer, then that's going to cause the ultimate complication of death. And I think the balance has shifted a little bit to being a little bit more, radical in terms of our approach of re-radiation. But it's a really big question. Thank you.
Quite a provocative editorial in the Red Journal on that topic a few weeks ago. Yeah. I had one question, so I was just wondering. You're talking about the attempts to get dose escalation, to get positive results from dose escalation, and so far we're not really there yet. I'm wondering how you feel about the opposite in terms of de-escalation. Do you think in terms of dose, or in terms of even the volumes and the nodal volumes in our traditional approach to volumes, that maybe we are going to go down that route as well? What's your thoughts on that?
So I think one thing is our outcomes, particularly in stage 3 non-small cell lung cancer, are not yet great. So this is not quite the setting of HPV positive head and neck cancer where we have very good outcomes and we think, might we be able to dose escalate? But still the question remains, if there are some nodes with very minimal microscopic disease, also for delivering concurrent therapies with it and maybe adjuvant immunotherapy, can we start to bring the dose down to lymph nodes compared to the primary tumor? I think it's a very good question. I think it's not anywhere near ready prime time yet, and it's actually very hard to see how you might bring that through a whole process and bring a trial where you combine those two approaches, randomize patients to those approaches, particularly when outcomes are not yet good. So I think, yes, whilst dose de-escalation might be important in certain scenarios, I think we're nowhere near there yet.
Oh, Michelle, I see you have a question.
Thank you. Sorry, I have to put my hand up because I can't type in the Q&A. Thanks, Gerry. That was terrific. I was really interested in the work you presented of George Walls about the dose to the pulmonary vein. And I was just wondering, you showed the kind of lack of evidence of proton beam therapy in this patient cohort. But could proton beam therapy, I'm just thinking, the exploitation of the distal penumbra, could that actually work quite well for the pulmonary vein, sparing of the pulmonary vein, or do you think, it's too expensive a modality to be using just for that?
Well, I think leaving the cost function out of it, I think that certainly proton therapy is really brilliant at trying to avoid normal tissue structures. It works best where you've got, some degree, a little bit of separation between the tumor and, where the organ itself is. But I think, the one difficulty with proton therapy is the dose delivery, though it's improved massively over the last 20 years, the image guidance is still a little bit behind the curve compared to what we can deliver. And I think also the planning techniques, certainly, in terms of that arc-type therapy, it's getting there with proton therapy, but it's not there just yet. So I think it's a little bit behind the curve in that way. And as you rightly say, of course, also the cost function there. But I think certainly in all of that, one of the problems we have with our current photon-based delivery is you have to put the dose somewhere. If you're trying to avoid, say, the pulmonary vein structures, you may have to put the dose in the lung, or you may have to put the dose in the cord or esophagus somewhere else. It really is hard when you've got nodal involvement, as you commonly do in stage 3 non-small cell, to try and avoid, some critical metacellular structure. But proton therapy might be able to do that. But I think we're still looking as to how we optimize it. I think also, in that kind of treatment time on the couch, we presume, when we put a patient on a couch that, they don't move, but they do move. Despite all our best attempts at mobilization, I think when we've got smaller margins, that becomes much more critical. When we're dealing with motion management, that's again highly critical. And I think that bit on proton therapy, there's a lot of time spent on couch compared to proton therapy, and I think that probably does matter in the end.
Thank you.
We have 2 minutes left, and we have one more question from Laura, actually. Do you think we're going to move to treating 7 days a week? Do you think that there's going to be a change in our approaches?
Oh, goodness me. I think the problem is our fractionation schedules aren't ready yet for 7 days a week. It makes sense in terms of the biology, but don't forget, if we did that, we probably have to, if we're thinking of a standard dose of, say, 60 gray and 30 fractions, we probably have to tailor that a little bit, because if we did that 7 days a week, we see an uptick, particularly in those acute responding tissues such as the esophagus. So they're going to get a lot more you'll see a lot more esophagitis because they haven't had that chance to repair over the weekend as they would do. Of course, the tumor is also getting a chance to repair, but logically it makes sense. To deliver that societally is a lot more challenging. So I think, and of course it depends on your resource setting and your workforce setting and a lot of other factors around that. But, if you go back to the chart study, it was delivered, don't forget, in the 90s in the UK, with a lot of those challenges the UK had at that time to deliver. So it is technically possible, but, it wasn't adopted in a much more widespread manner simply because I think every other department found it very hard to get there. So we're still very hard to get people in to treat in the weekend, and that would be a challenge 7-day working, but it would require a change in our fractionation or considerations around that.
That's great, thank you. Okay, so we're actually at 1 o'clock on the button, so I suppose I just wanted to thank you again, Professor Hanna, for this great presentation, and I know you're happy to answer any queries by email. If anybody hasn't gotten a chance to ask a question, please send them to Gerry via email. And just to note for everyone, I suppose that our webinar will be available on our website. So today's recording will be made available on our website, and there's going to be a little break over the summer, and they'll be resuming, our series will be resuming in September. So keep an eye out on our social media channels for advertisements of our next topics. So thank you very much, Gerry, and thanks to all the participants for attending today.
Thanks, Sarah.